Every few months, I sit down with a patient who has done everything right. They have eaten the vegetables. They have walked the neighborhood loop. They have taken their medication exactly as prescribed, often for years, without missing a single dose. And they come to me with a quiet frustration hidden behind polite conversation. "Doctor," they say, "something just does not feel the same anymore. I am more tired than I used to be. I get winded doing things that never bothered me before. I had a fall last month, nothing serious, but I do not feel as steady on my feet." And when I look at their chart, I almost always see the same pattern. Not one dramatic event, not a sudden diagnosis, just a slow, almost invisible decline that has been happening right under their nose and right under their doctor's nose for years. Now let me tell you something that might surprise you. I am not a primary care physician. I am a cardiac surgeon, and the reason patients get referred to me is not because of a heart attack or a bypass gone wrong. It is because they are scheduled for surgery, and something unexpected shows up on their preoperative testing. Something that should not be there for someone who has been so careful with their health. And here is the question I have learned to ask every single time. What medications are you taking? Not the obvious ones. Not the blood pressure pill or the cholesterol medication or the diabetes drug. I want to know about the one that seems so harmless, so routine, so universally recommended that nobody ever thinks twice about it. The one that millions of seniors take every single morning, often without food, often without water, often without a single moment of reflection. Here is the warning I wish every primary care doctor would give, but almost none do. And here is the warning I give now, as a cardiac surgeon who has seen the inside of enough arteries to know what actually happens inside the aging body. That common pill, the one you probably have in your bathroom cabinet right now, the one your doctor may have told you to take without ever explaining the trade-offs. It is not as safe for seniors as you have been led to believe. In fact, for a significant number of people over the age of 60, it may be doing more harm than good. Not dramatically, not all at once, but slowly, quietly, in ways that look like normal aging but are not aging at all. By the end of this video, you are going to understand exactly which medication I am talking about. You are going to understand why your risk changes so dramatically after a certain age. You are going to learn the 3 things that almost nobody tells you about this pill, including something your doctor may not even know. And most importantly, you are going to leave with a completely different way of thinking about medication safety, not just for yourself, but for everyone you love who has passed that invisible line into the second half of life. But before I tell you the name of this medication, and I promise you I will, I need you to understand something critical. This is not a video about stopping your medication. It is not a video about fear. And it is absolutely not a video about rejecting modern medicine. Quite the opposite. This is a video about the difference between treating a young body and treating an aging body. Because here is the truth that changes everything, and it is a truth that most medication guidelines still fail to fully account for. Your body at 60 is not the same as your body at 40. Your body at 70 is not the same as your body at 60, and a medication that is perfectly safe, even beneficial for a 50-year-old, can become a source of hidden harm for a 70-year-old. Not because the medication changed, but because you changed. And the medication I am about to discuss, the one that top heart surgeons are increasingly warning seniors about, is the perfect example of this principle. It is a medication that works exactly as intended. It does what it is supposed to do. And yet, for the aging body, what it does may not be what you need anymore. So let me ask you to pause for just a moment. Open your medicine cabinet or think about the pills you take every morning. Is there one that you have been taking for years without ever questioning? One that your doctor prescribed so casually that you assumed it must be completely harmless? One that you have never seen a warning about on television or in a magazine? If you are over the age of 60, and especially if you are over the age of 70, I want you to pay very close attention to what comes next. Because the story I am about to tell you is not a story about a dangerous drug. It is a story about how our understanding of safety changes as we age. And it is a story that could change the way you think about every single medication you take, starting today. Let me start this part with a question that sounds simple but is actually surprisingly difficult to answer. What is the most commonly prescribed medication for seniors in the United States? If you said a blood pressure medication, you would be warm. If you said a cholesterol medication, you would also be warm. But you would not be correct. The answer is a class of medications so common, so inexpensive, so widely available that you can buy many of them without a prescription at all. I am talking about non-steroidal anti-inflammatory drugs, NSAIDs for short. And the most famous member of this family is a little white pill that has been in medicine cabinets for decades, ibuprofen, but also naproxen, which you might know as Aleve, and the prescription-strength versions like meloxicam and diclofenac. Now, before anyone misunderstands me, let me be extremely clear. These medications are not poison. They are not evil. They've helped millions of people manage pain, reduce inflammation, and live more comfortable lives. For acute injuries, for short-term use, for younger adults, they are often exactly the right tool for the job. But here is the problem, and it is a big problem. These medications have become so normalized that we have stopped thinking of them as drugs at all. We treat them like candy. We take them for headaches, for back pain, for arthritis, for muscle soreness after gardening, for that mysterious ache in the knee that showed up one day and never really left. We take them before bed to sleep better. We take them in the morning to start the day without stiffness. And because they work so well, because they are so effective at blocking pain, we never stop to ask what else they might be doing inside our bodies. This is the common misunderstanding I want to address. Most people believe that over-the-counter pain relievers are essentially harmless. They believe that the worst thing that could happen is an upset stomach. They believe that if a medication is available without a prescription, it must have passed some higher standard of safety. And here is where the truth gets uncomfortable. The safety profile of a medication is not absolute. It is relative. It depends on who is taking it, for how long, and most critically, at what age. The hidden mechanism I want to walk you through is something I have seen with my own hands in the operating room. And once you understand it, you will never look at that little white pill the same way again. NSAIDs work by blocking an enzyme in your body called cyclooxygenase. There are two versions of this enzyme, creatively named COX-1 and COX-2. When you block these enzymes, you block the production of substances called prostaglandins. Prostaglandins are responsible for pain and inflammation. So when you have a swollen ankle or a headache, blocking prostaglandins makes you feel better. That is the intended effect. That is why these pills exist. But here is what the commercials do not tell you. Prostaglandins are not just responsible for pain. They are also responsible for protecting your stomach lining from your own digestive acids. They help regulate blood flow to your kidneys. They help maintain the delicate balance of fluids and electrolytes in your body. And most importantly for this conversation, they help your blood vessels relax and stay flexible. So what happens when you block these enzymes every day for months or years? You get less pain, yes, but you also get a stomach that is more vulnerable to bleeding ulcers. You get kidneys that are working under constant strain, and you get blood vessels that gradually lose their ability to relax and dilate properly. In a young, healthy body, these trade-offs are usually acceptable. The body has reserve capacity. It can compensate. The stomach lining repairs itself quickly. The kidneys have extra filtering power. The blood vessels have plenty of flexibility to spare. But in an aging body, that is where the math changes completely. By the time you reach your 60s and 70s, your kidneys are not what they used to be. You have lost some of that reserve capacity naturally, simply as a function of time. Your stomach lining is thinner and more fragile. Your blood vessels are stiffer, less elastic, more dependent on those prostaglandins to maintain healthy blood flow. And here is the part that keeps me up at night as a surgeon. When I operate on a patient who has been taking NSAIDs for years, I can see the difference in their tissues. Not in a dramatic, obvious way, but in subtle ways that matter enormously. The bleeding is harder to control. The blood vessels are more friable, more likely to tear. The healing process is slower, more complicated. I had a patient once, a 72-year-old woman who had been taking ibuprofen for her knee arthritis for over a decade. She was healthy otherwise, active, sharp as a tack. She came in for a routine heart valve replacement, the kind of surgery I have done thousands of times, and everything went perfectly, until it did not. Her kidneys shut down on the second day after surgery. Not completely, but enough to worry us. Her blood pressure kept dropping despite all the medications we gave her. Her stomach started bleeding from a stress ulcer that should not have happened. She survived, thank goodness. But her recovery took twice as long as it should have. And when I went back through her chart, I saw it. Daily ibuprofen. For 10 years. No one had ever told her to stop. No one had ever explained the risk. That is the overlooked problem. Not that doctors are malicious, not that pharmaceutical companies are hiding data, but that the medical system is built for acute problems, not chronic prevention. Your primary care doctor has 15 minutes with you. They are focused on your blood pressure, your cholesterol, your diabetes. They do not have time to rethink every medication you have been on for a decade. And that little white pill, the one that seems so harmless, simply falls through the cracks until you end up on my operating table. And then it is no longer invisible. Then it is very, very real. Let me introduce you to someone I will call Richard. Richard is not his real name, but his story is real, and it is a story I have seen play out hundreds of times with only minor variations. Richard is 74 years old. He retired from teaching high school history about 9 years ago. He lives in a small town in the Midwest with his wife of 48 years. He has 2 grown daughters and 4 grandchildren who live about an hour away. By any reasonable measure, Richard is doing well for his age. He walks 2 miles every morning, weather permitting. He does the daily crossword puzzle. He still drives himself to the grocery store and to his medical appointments. He takes a blood pressure medication that has kept his numbers stable for years. He watches his salt intake. He has never smoked. He has a glass of red wine with dinner most nights and considers that his one small vice. And about 5 years ago, Richard started noticing that his knees were bothering him. Nothing dramatic, just a dull ache when he stood up from his favorite armchair, a little stiffness when he got out of bed in the morning, the kind of thing that he and his wife both dismissed as normal aging. Because is that not what we all do? We wake up with a new ache, a new stiffness, a new limitation, and we tell ourselves the same thing. I am just getting older. This is what it feels like. Richard mentioned it to his primary care doctor during his annual physical, and his doctor, a perfectly competent and caring physician, did exactly what most doctors would do. He recommended over-the-counter ibuprofen. Take it when you need it, he said. Start with 200 milligrams and see how you feel. It is safe, it is effective, and it will help you stay active. That conversation lasted about 30 seconds. Neither of them thought about it again. Why would they? It was a routine recommendation for a routine complaint. Richard went to the pharmacy that same afternoon and bought a large bottle of ibuprofen. Not the expensive brand name, the store brand, the one that came in a value size because it was cheaper per pill. For the first few months, Richard took ibuprofen maybe 2 or 3 times a week, only on the days when his knees really bothered him. But as the months turned into years, something shifted. The ache in his knees did not go away. If anything, it got a little worse. And the ibuprofen worked so well. 20 minutes after taking it, that familiar dull ache would fade into the background. He could walk his 2 miles without thinking about his knees at all. So Richard started taking it every day. Not because he was addicted, not because he was reckless, but because it made his life better. He could garden without pain. He could play on the floor with his grandchildren without dreading the moment he would have to stand back up. He could sleep through the night without being woken by that deep, gnawing ache in his joints. 400 milligrams every morning, right after breakfast. Sometimes another 400 in the evening if the day had been particularly active. This became as routine as brushing his teeth. He did not think about it. He did not question it. Why would he? His doctor had said it was safe. The bottle said it was for pain relief. And it worked. Now, I want you to notice something important about Richard's story. Nothing dramatic happened. There was no moment where he took an ibuprofen and collapsed. There was no emergency room visit. There was no flashing red warning light. What happened instead was so slow, so gradual, so easily explained away, that Richard himself did not even notice it until long after it had taken hold. The first thing he noticed was that he was more tired than he used to be. Not the kind of tired that comes from a bad night of sleep, the kind of tired that settles into your bones. The kind where climbing a flight of stairs leaves him winded in a way that never used to happen. He mentioned this to his wife. They both agreed it was probably just age. Maybe he was not walking as briskly as he thought. Maybe he needed to push himself a little harder. The second thing he noticed was that his blood pressure, which had been beautifully controlled for years, started creeping up. His doctor increased his blood pressure medication, then increased it again. Richard assumed this was also just age. He had heard that blood pressure naturally rises as you get older. He did not connect it to the little white pill he took every morning. The third thing he noticed was that his annual blood work showed a slow but steady decline in his kidney function. His doctor mentioned it casually. Just a little lower than last year, but nothing to worry about. It is probably just age, the doctor said, and Richard nodded and went home and took his ibuprofen. Do you see the pattern here? Every single warning sign was right there in plain sight, but each one, by itself, looked like normal aging. Fatigue, rising blood pressure, slowly declining kidney function. None of these things screamed medication side effect. They whispered, and whispers are very easy to ignore. The moment everything changed for Richard was not dramatic either. He was in the kitchen, reaching for a glass on the top shelf, and he felt a sudden, sharp pain in his shoulder. Nothing major, probably just a strained muscle. He took 2 ibuprofen and went about his day. But the pain did not go away. And over the next few days, it got worse. He could not lift his arm above his shoulder. He could not sleep on that side. He finally went to see an orthopedic surgeon. The surgeon ordered an MRI, and the MRI showed something that stopped everyone cold. Richard had not just strained a muscle. He had a partial tear in one of the tendons of his rotator cuff, and the tissue around the tear did not look healthy. It looked thin. It looked fragile. It looked like it had been bathed in something that had weakened it over time. The orthopedic surgeon asked Richard the question I want every senior to be asked. What medications are you taking? Richard listed his blood pressure pill. And then he said, "Oh, an ibuprofen. 400 milligrams every morning, sometimes more. I have been taking it for about 5 years." The surgeon closed his eyes for a moment. Then he explained something that Richard had never heard before. NSAIDs do not just block pain. They also interfere with the healing of tendons, ligaments, and bones. They reduce the inflammation that is actually necessary for tissue repair. They make tendons more likely to tear and less likely to heal once they do. Richard had no idea. Neither did his primary care doctor. Neither did the bottle that said, "for pain relief." And now he was facing a shoulder surgery that might have been preventable, on a tendon that might have been healthier, if only someone had explained the trade-off 5 years earlier. Richard's story is not unusual. It is not exceptional. It is, tragically, the rule. Millions of seniors are taking NSAIDs every single day, for years on end, with no real understanding of what these medications are doing to their kidneys, their blood pressure, their stomach, their tendons, and their blood vessels. And the reason they do not know is not because the information is hidden. It is because no one has connected the dots for them in a way that makes sense. That is what I want to do for you now. I want to connect the dots. I want to show you the hidden mechanism that turns a helpful medication into a hidden danger. And I want to give you the 3 insights that most people miss, including most doctors, about how these medications affect the aging body. Now I need you to imagine something with me. Imagine the inside of an artery, not as a diagram in a textbook, but as a living, dynamic structure. It is not a rigid pipe. It is not a piece of plumbing. An artery is a living organ made of layers of muscle and elastic tissue, constantly responding to the demands of your body. When you exercise, your arteries relax and widen to deliver more blood to your muscles. When you stand up, your arteries constrict slightly to keep blood flowing to your brain. When you sleep, your arteries slow down their work, matching the reduced demand of a body at rest. This constant dance of relaxation and constriction is happening every second of every day without you ever thinking about it. Now let me introduce you to the chemical messengers that make this dance possible. They are called prostaglandins, and I mentioned them briefly before, but now I want you to really understand what they do. Prostaglandins are produced in nearly every tissue in your body. They are not stored anywhere. Your body makes them on demand, in tiny quantities, right where they are needed. They have a half-life of seconds, meaning they are created, they do their job, and they are destroyed almost instantly. One of the most important jobs of prostaglandins is to keep your blood vessels relaxed and open. They do this by signaling the smooth muscle in your artery walls to let go, to loosen, to allow blood to flow freely. Without prostaglandins, your arteries would be in a constant state of mild constriction, always slightly tight, always working a little harder than they should. Now let me tell you what happens when you take an NSAID. Whether it is ibuprofen, naproxen, meloxicam, or any of the others, these medications work by blocking the enzyme that produces prostaglandins. Remember, cyclooxygenase, COX for short. When you block COX, you block the production of prostaglandins everywhere in your body, not just in your painful knee, in your stomach, in your kidneys, in your blood vessels, everywhere. This is the hidden mechanism that most people never understand. The same pathway that creates pain also protects your stomach, supports your kidneys, and keeps your blood vessels flexible. You cannot block one without blocking the others. The medication does not know where your pain is. It works systemically. It works everywhere. For a young person, this is usually fine. Their bodies have enough reserve capacity to compensate. Their stomach lining regenerates quickly. Their kidneys have extra filtering units to spare. Their blood vessels have plenty of flexibility even without full prostaglandin support. But for an aging body, the math changes completely. And here is where the cause and effect chain becomes absolutely critical to understand. Let us start with the kidneys. Your kidneys filter your blood about 30 times every single day. They are incredibly hardworking organs, and they are also incredibly vulnerable. The blood flow to your kidneys is regulated in large part by prostaglandins. When your blood pressure drops, when you become dehydrated, when your body is under stress, prostaglandins step in to keep blood flowing to your kidneys. They are your kidneys' backup system, their safety net. Now imagine you are a 70-year-old person who has been taking ibuprofen every day for years. Your prostaglandin levels are chronically suppressed. Your kidneys have been operating without their safety net for a long time. They have been working harder than they should, compensating, managing, surviving. Then one day something happens. You get a stomach virus and become dehydrated. Or you start a new blood pressure medication that lowers your pressure a little too much. Or you have surgery and your body goes into a state of stress. Without prostaglandins to protect them, your kidneys can fail. Not dramatically, not with fireworks and sirens, but quietly, over a few days as their function slips away. I have seen this happen more times than I can count. A patient comes in for a routine procedure, perfectly healthy by all standard measures, and 3 days later they are on dialysis because their kidneys never recovered from the insult of surgery combined with years of NSAID use. Now let us talk about the stomach. Your stomach produces hydrochloric acid strong enough to digest food. The reason this acid does not digest your stomach itself is because your stomach lining produces a thick layer of mucus, and prostaglandins are essential for maintaining that mucus layer. They also help regulate blood flow to the stomach lining and promote the repair of microscopic damage that happens constantly. When you take an NSAID, you suppress those protective prostaglandins. Your stomach lining becomes thinner, more fragile, more vulnerable to acid. At first, you might not notice anything, but over months and years, tiny erosions form. Small blood vessels become exposed, and one day, sometimes for no obvious reason, one of those vessels opens. Bleeding in the stomach or upper intestine is one of the most common serious side effects of NSAID use in seniors. And here is the cruel irony. The bleeding is often silent. There is no dramatic pain, no vomiting of blood. Instead, the blood leaks slowly into your digestive tract, and over weeks or months you become anemic. You feel tired. You feel weak. You feel short of breath when you exert yourself. You assume this is just aging, and all the while you keep taking the medication that is causing the problem. Now let me tell you about the cardiovascular effect, because this is the one that surprises even some doctors. Remember how prostaglandins help keep your blood vessels relaxed? When you block them chronically, your blood vessels exist in a state of slightly increased tone, slightly more constricted, slightly tighter than they should be. This raises your blood pressure, not dramatically, but consistently. 2 to 5 points on the top number, the systolic pressure. 2 to 5 points does not sound like much, but let me put this in perspective. A 5-point increase in systolic blood pressure across the entire population would lead to a significant increase in heart attacks, strokes, and heart failure. Now multiply that by millions of seniors taking NSAIDs every day, and you begin to see the scale of the problem. There is more, and this is the part that I think about every time I am in the operating room. NSAIDs also affect platelet function. Platelets are the tiny cells in your blood that form clots. When you cut yourself, platelets rush to the site and stick together to stop the bleeding. NSAIDs make platelets less sticky. They interfere with their ability to clump together. This is why aspirin, which is also an NSAID, is used to prevent heart attacks and strokes. But here is the critical distinction. Aspirin blocks platelets irreversibly, and it does so at a very low dose. Other NSAIDs block platelets reversibly, but they also do other things that aspirin does not. And when you combine the antiplatelet effect with the stomach weakening effect and the blood pressure raising effect, you have a recipe for trouble. I had a patient once, a lovely woman in her late 60s, who came in for a hip replacement. She had been taking naproxen for arthritis for years. Her surgery went beautifully, but on the third day after surgery, she developed a massive bleed in her gastrointestinal tract. We transfused her. We took her back to the operating room. We did everything we could. She survived, but her recovery was a nightmare of complications. When I reviewed her chart, I saw that her surgeon had told her to stop the naproxen 2 weeks before surgery. But she had not. Not because she was disobedient, but because no one had explained why it mattered. She thought it was just a precaution. She thought a few days would not make a difference. She had no idea that the medication she was taking to feel better was setting her up for the most dangerous complication of her entire surgical experience. So let me lay out the cause and effect chain as clearly as I can. NSAIDs block COX enzymes. Blocking COX enzymes reduces prostaglandins. Reduced prostaglandins mean less stomach protection, less kidney protection, less blood vessel relaxation, and altered platelet function. In a young body, the body compensates. In an aging body with less reserve capacity, the compensation fails. And what was once a helpful medication becomes a hidden source of harm. This is not a flaw in the medication. It is a feature of biology. And it is a feature that changes completely depending on your age, your kidney function, your blood pressure, your other medications, and your overall health. What is safe for one person may be harmful for another. What is safe for a month may be harmful for a year. What is safe at 50 may be dangerous at 70. And this is why the conversation about NSAIDs cannot be reduced to a simple warning or a simple reassurance. It requires nuance. It requires understanding. and it requires the 3 insights I am about to share with you. Insights that most people miss entirely, but that could change the way you think about pain relief for the rest of your life. Now we arrive at the heart of what I want you to understand. Not just what the problem is, but what almost everyone misses about it. These 3 insights did not come from textbooks or lectures. They came from the operating room, from post-operative conversations with confused and frustrated patients, and from years of watching the same patterns repeat themselves over and over again. Insight number 1, and I want you to really sit with this one. The risk of NSAIDs is not about the medication itself. It is about the duration of use combined with age. And most doctors are still thinking in terms of acute treatment, not chronic prevention. Let me explain what I mean. When a 30-year-old pulls a muscle playing basketball, their doctor might tell them to take ibuprofen for 3 to 5 days. That is acute treatment. The medication is used for a defined period, the injury heals, and the medication stops. In that scenario, the benefits almost always outweigh the risks. But here's what happens when that same mindset gets applied to a 70-year-old with chronic knee pain. The doctor says, take ibuprofen when you need it, and the patient hears, take ibuprofen every day because my knees hurt every day. And suddenly, a 3 to 5 day treatment becomes a 3 to 5 year treatment, or a 10-year treatment, or a 20-year treatment. Here is the insight that most people miss. The safety data for NSAIDs comes largely from studies lasting weeks or months, not years. We have surprisingly little high-quality data on what happens when a 70-year-old takes these medications every single day for a decade. But we have plenty of clinical observation. And what we observe is not reassuring. I had a conversation with a nephrologist, a kidney specialist, a few years ago. He told me that in his practice, he sees at least 1 new patient every week with unexplained kidney dysfunction. And in nearly every case, when he digs into their medication history, he finds chronic NSAID use. Years of daily ibuprofen or naproxen. And here's the part that haunts him. By the time he sees them, the damage is often permanent. You cannot grow new kidney filters. Once those filtering units are gone, they are gone. So insight number 1 is this. For seniors, the definition of short-term use needs to be much shorter than you think. A few days for an acute injury, a week for a bad flare-up. But beyond that, you need to have a different conversation with your doctor. Not the 30-second conversation Richard had. A real conversation about risks, alternatives, and the specific ways your age changes the equation. Now let me share insight number 2, and this one often surprises people the most. The gastrointestinal and kidney risks of NSAIDs are well known, but the cardiovascular risks are underappreciated, especially in people who have never had a heart problem. Remember what I said about prostaglandins and blood vessel relaxation. When you suppress prostaglandins chronically, your blood vessels lose some of their ability to relax. This increases the workload on your heart. Your heart has to pump against slightly tighter arteries, day after day, year after year. Over time, that extra workload adds up. But there is another layer to this that is even more concerning. NSAIDs can interfere with the effectiveness of common blood pressure medications. If you take a diuretic, also known as a water pill, or an ACE inhibitor, or an ARB, these medications work in part through pathways that involve prostaglandins. When you add an NSAID, you can blunt the effect of your blood pressure medication. Your numbers creep up, your doctor increases your dose, and no one connects the dots back to that little white pill. I have seen patients on 3 different blood pressure medications, struggling to get their numbers under control, when the real problem was not their blood pressure at all. The real problem was that they were taking ibuprofen every day, and no one had ever told them to stop. When they stopped, their blood pressure improved within weeks, sometimes dramatically. And then there is the fluid retention. NSAIDs cause your body to hold on to sodium and water. This can lead to swelling in your ankles and feet, and for people with heart failure, it can be dangerous. A patient with stable heart failure can be pushed into decompensation, meaning their heart can no longer keep up with the body's demands, simply by starting a daily NSAID. I have seen this happen. It is not rare. So insight number 2 is this. Even if your heart feels fine, even if you have never had a heart attack, chronic NSAID use is quietly affecting your cardiovascular system in ways you cannot feel, raising your blood pressure, blunting your medications, causing fluid retention, and increasing your risk over time. This is not about fear. It is about awareness. It is about understanding that the absence of symptoms is not the same as the absence of harm. Now let me give you insight number 3, and this is the one I wish every senior would write down and keep somewhere visible. The biggest mistake is not taking an NSAID. The biggest mistake is taking it without a clear plan for how long and why, and without regular monitoring. Here's what I mean. Many of the patients I see who have been harmed by NSAIDs were not taking them recklessly. They were taking them exactly as directed. They were following their doctor's initial advice, but that advice was never updated. No one ever said, "Let us check your kidney function in 6 months to make sure this is still safe." No one ever said, "Let us try reducing the dose or taking it only on your worst days instead of every day." No one ever said, "Let us have a conversation about alternatives, about physical therapy, about topical anti-inflammatories that work locally without affecting your whole body." The medication became automatic, and automatic is dangerous. I want you to think about your own medication routine. Is there anything you take every day that started as a temporary solution? Anything you have been taking for years without ever stopping to ask if you still need it? Anything that your doctor prescribed casually, almost as an afterthought, and that you have never discussed since? These are the questions that almost never get asked in a 15-minute primary care visit, but they are the questions that could save your kidneys, that could protect your stomach, that could keep your blood pressure under control without ever increasing your medications. Let me give you an example of what a safer approach looks like. For chronic joint pain, especially in the knees or hands, topical NSAIDs like diclofenac gel can be remarkably effective. You rub the gel directly onto the painful area. A small amount is absorbed into your bloodstream, far less than what you get from an oral pill. The medication goes where it is needed, and the rest of your body is largely spared. This is not a perfect solution for everyone, but for many seniors, it is a dramatically safer option than daily oral ibuprofen. Another alternative is acetaminophen, which you know as Tylenol. Acetaminophen works differently. It does not affect prostaglandins the same way. It does not harm the kidneys or the stomach or the blood vessels. But it has its own risks, primarily to the liver, especially if you take more than the recommended dose or if you drink alcohol regularly. Acetaminophen is not a free pass, but for many types of pain, especially osteoarthritis, it can be effective and safer than chronic NSAID use. And then there are non-medication approaches. Physical therapy to strengthen the muscles around a painful joint. Weight loss to reduce the load on your knees. Topical capsaicin cream, which works by depleting a pain-signaling chemical in your nerves. Acupuncture, which has genuine evidence for certain types of chronic pain. These approaches require more effort than swallowing a pill. They require time and commitment, but they also do not put your kidneys at risk. Here is the deeper point. When you take a medication every day for years, you are making a trade-off. You are trading a known benefit for a known risk. The problem is that most people only know about the benefit. No one explained the risk. Or if they did, it was in a rushed sentence that did not land, did not stick, did not change behavior. Insight number 3 is this. Any medication you take daily deserves a regular review. Not once every 5 years when something goes wrong, at least once a year. With your doctor, with your actual medication list in front of you. Asking specific questions. How long do I need to take this? Is the dose still appropriate for my age? Are there safer alternatives? What monitoring do I need to make sure this is not causing silent harm? These are not difficult questions, but they rarely get asked, and they rarely get answered. And that silence, that gap between what we know and what we do, is where the harm happens. Not because anyone is malicious, not because the medication is evil, but because our system is not built for thoughtful, ongoing medication management for the aging patient. And until that changes, the responsibility falls on you, on your awareness, on your willingness to ask the questions that no one else is asking for you. So here we are at the end of this conversation, and I want to bring everything back to something simple, something you can actually use. Because the goal of this video has never been to scare you. It has never been to make you afraid of your medicine cabinet. And it has absolutely never been to suggest that you should stop a medication your doctor prescribed without having a proper conversation first. The goal has been to give you a new lens, a different way of seeing, a framework for thinking about medication safety that takes into account the most important variable of all, you, and your age, and the way your body has changed over the decades. Let me reframe everything we have discussed in the clearest possible terms. Non-steroidal anti-inflammatory drugs, whether you buy them over the counter or get them by prescription, are effective tools for managing pain and inflammation. They work. That is why they are popular. That is why they are everywhere. But their safety profile changes dramatically as you age, and as your duration of use extends from days into months and years. For a healthy person under the age of 60, using an NSAID for a few days to treat an acute injury or a temporary flare-up of pain is generally safe. The benefits usually outweigh the risks. But for a person over the age of 60, and especially over the age of 70, the calculation shifts. Your kidneys have less reserve. Your stomach lining is more fragile. Your blood vessels are stiffer. Your blood pressure is harder to control. And the same dose, the same medication, the same duration that was safe a decade ago may not be safe today. This is not a judgment on you. It is not a judgment on your doctor. It is simply biology. And biology does not care about convenience. It does not care about habits. It does not care that you have been taking that little white pill every morning for years, and it has become as automatic as breathing. Biology only cares about what is actually happening inside your body, moment by moment, day by day. So what do you do with this information? Let me give you a practical framework, not a list of rules because rules are too rigid for the complexity of real human bodies, but a way of thinking, a set of questions you can ask yourself and your doctor. First, ask yourself this: am I taking an NSAID every day? Not occasionally, not when my knee really hurts, but every single day as part of my routine. If the answer is yes, you need to have a conversation, not because you are doing something wrong, but because you deserve to know the trade-offs. You deserve to make an informed decision rather than an automatic one. Second, ask yourself this: how long have I been taking this medication? If the answer is more than 3 months, you have moved beyond acute treatment into chronic use. And chronic use in an aging body requires a different level of scrutiny. It requires monitoring. It requires regular checks of your kidney function, your blood pressure, and your complete blood count to watch for silent bleeding. Third, ask yourself this: have I ever had a conversation with my doctor about whether I still need this medication? Not whether it helps, not whether it makes me feel better, but whether the benefit still outweighs the risk, given my current age and my current health status. If you cannot remember having that conversation, or if it never happened, then today is the day to start. Now let me be extremely specific about what that conversation should look like. When you see your doctor, whether it is your primary care physician, your rheumatologist, or your orthopedic surgeon, I want you to say these exact words: I have been taking ibuprofen or naproxen or whatever medication you are taking every day for X number of months or years. I want to know if this is still safe for me at my age. Can we check my kidney function? Can we check my blood count? And are there safer alternatives we should consider? These are not confrontational questions. They are not accusatory. They are the questions of an engaged, thoughtful patient who understands that medicine is not a set of static rules, but an ongoing process of reassessment. Any good doctor will welcome these questions. Any good doctor will appreciate that you are taking an active role in your own health. And here is what a good doctor might offer you in return. They might check your blood work, specifically your creatinine and your estimated glomerular filtration rate, which tell you how well your kidneys are working. They might check your hemoglobin to make sure you are not bleeding silently into your stomach or intestines. They might check your blood pressure, not just once, but over time, to see if stopping the NSAID improves your numbers. They might suggest alternatives, topical NSAIDs like diclofenac gel, which deliver medication directly to the painful joint with minimal systemic absorption, acetaminophen, which works differently and has a different safety profile, physical therapy to strengthen the muscles around your arthritic joints, weight loss if that is appropriate for you. Even simple things like using a cane or wearing more supportive shoes can reduce the load on a painful knee more than you might imagine. They might suggest a different schedule. Instead of taking an NSAID every day, perhaps you take it only on your worst days. Perhaps you take the lowest effective dose rather than the standard dose. Perhaps you use it for a week, then take a week off, to give your kidneys and stomach a chance to recover. These are not perfect solutions, but they are better than the all-or-nothing approach that most people fall into. Now I want to address something important. What if you have been taking an NSAID for years and your doctor has never raised a concern? Does that mean your doctor is incompetent? Almost certainly not. It means your doctor, like most doctors, is overwhelmed. It means your doctor, like most doctors, is focused on the problems you bring into the room, not the problems that are hiding in plain sight. It means your doctor, like most doctors, assumes that if you have been taking a medication for years without complaint, it must be working for you. This is not malice. This is the reality of a healthcare system that rewards speed over thoughtfulness, volume over depth, reactive care over preventive awareness. The system is not designed to catch the slow, silent harms of chronic medication use. That is why the responsibility has to shift, at least in part, to you. Not because it is fair, but because it is true. Let me close with a story. A few months ago, I had a patient in her late 60s who came to see me for a preoperative consultation. She was scheduled for a knee replacement and she was nervous. Not about the surgery itself, but about the recovery. She had heard horror stories. She was afraid of the pain. She was afraid of being immobile. She was afraid of losing her independence. We talked through all of it. The surgery, the hospital stay, the rehabilitation, the expected outcomes. And then I asked her my standard question. What medications are you taking? She listed her blood pressure pill, her cholesterol medication, and then she paused. She said, "Well, I take ibuprofen for my knee, but I know you are going to tell me to stop before surgery. Everyone tells me to stop before surgery." I said, "Yes, I am going to tell you to stop, but I also want you to understand why." So I explained what I have explained to you today: the effect on platelets, the risk of bleeding, the strain on the kidneys, the interference with healing. She listened carefully, and then she asked me a question that I will never forget. She said, "If this medication is so risky for surgery, why is it safe for me to take every day for years?" And that, right there, is the question that changes everything. Because the honest answer is, for many seniors, it is not safe. It is not catastrophically unsafe. It is not poison, but it is a source of small, cumulative, hidden harm that adds up over time. And because the harm is hidden, because it looks like normal aging, because it whispers instead of shouts, most people never connect the dots until something goes wrong. So here is my calm, confident, practical takeaway for you. You do not need to be afraid of your medication, but you do need to be thoughtful about it. You do need to question it. You do need to treat it as what it is, a powerful biological tool with benefits and risks that change as you change. If you are over 60 and you are taking an NSAID every day, have the conversation. Not because something is definitely wrong, but because something might be wrong and you deserve to know. Not because you need to stop, but because you need to understand. And because the understanding itself, the awareness, the clarity, is the first step toward making better decisions for your long-term health. This is not about fear, it is about respect. Respect for the complexity of your body, respect for the power of medications, and respect for the truth that what worked for you at 50 may not be what is best for you at 70. Aging is not a disease, it is a process, and the best medicine, the wisest medicine, adapts as that process unfolds. Thank you for spending this time with me. If this conversation has been useful to you, I hope you will share it with someone you love, because the person most at risk for the hidden harms we have discussed today is not the person watching this video. It is the person who never watches it. The person who keeps taking that little white pill every morning, year after year, without ever asking the one question that could change everything. Is this still safe for me? Take care of yourself. Be thoughtful. Be curious. And I will see you in the next video.